Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
In a report on research, diagnosis, and treatment, we bring you to the frontiers of health. This series tells you the progress being made by medicine, dentistry, public health, and the other health sciences in man's eternal struggle against illness. This is Program 10, dealing with orthodontics. You're going to meet 4 children and see how dentists can intercept the need for comprehensive braces in later childhood. Now here for Frontiers of Health is Adelia Bucas.
Thousands of American boys and girls wear braces on their teeth at some time in their life. Actually, braces seem almost as common as blue jeans or a butch haircut. But we hope that sometime in the future, it will be actually an uncommon sight to see a 12-year-old youngster with braces on all of his or her teeth. For today there is a new trend taking hold in our dental schools. And today the Frontiers of Health, with the help of 4 youngsters, is going to demonstrate that trend for you. And here to help us demonstrate the trends in the field of orthodontics is Dr. Moyers, who is director of the orthodontic clinic at the dental school at the university. Dr. Moyers, first tell me exactly what do you mean by orthodontics?
Orthodontics is a part of dentistry. It's the phase of dentistry that deals with problems in the growth of the facial region, the growth of the bones, the growth of the teeth, and the development and growth of the musculature around the face.
Well, then orthodontics is a specialty in the field of dentistry.
Yes, this is true. Although every dentist gets some basic training in orthodontics, the comprehensive treatment of difficult orthodontic problems is limited to the offices of specialists. We call them orthodontists.
Well, how many are there in the country, these specialists in orthodontics?
Only about 1,500. You can see with that few number of specialists, they're all busy. And although every family dentist can do these things, he usually sends these difficult ones off just to the orthodontist himself.
So that actually is the trend today for you to train the boys in the dental school in what you call interceptive orthodontics, so that you can sort of spare all of the rush to the specialist?
This is exactly what we try to do. We simply can't handle the problem in malocclusion. That's a bad word, but it simply means bite, bad children's bites. The orthodontist simply can't handle all of these himself, and so we're trying to train the new family dentist to handle as many as he can in his practice. Some can be prevented, some can be intercepted, and some of the more difficult ones can be minimized. We really have several types of these problems. Some of them are problems in tooth malpositions, teeth actually in the wrong place in the mouth. Others are problems in malfunctioning of the muscles around the facial region. The more difficult ones, and the ones that we have the greatest problem in intercepting, are those problems of disharmonious bone growth, of the actual bones of the jaws. The children we're going to see tonight, for example, are going to represent each one of those types of things. I think this drawing will show us one of the types of problems rather easily. The crucial time, so far as the orthodontist is concerned, is the period which we know as the mixed dentition. It's the time beginning about the age of 6, when the child has still in his mouth some of the primary teeth, and that means the baby teeth, this is our term for it, and some of the permanent teeth have come in. There's a period of about 6 years, from the age of 6 to 12, when both of these teeth are represented in the mouth. We call it the mixed dentition. This drawing represents It was actually taken from an X-ray of a child in this stage. This large tooth back here is the so-called 6-year molar. Up front, these two teeth are permanent incisors. In between are 3 primary teeth. Beneath them in the jaw are developing 3 permanent teeth. Our job during the mixed dentition is to maintain the integrity of these primary teeth so that this permanent tooth in the back doesn't have a tendency to drift forward.
In other words, you just don't want the youngster to lose the primary teeth by lack of care.
Certainly not. The most important thing that any child can have done from an orthodontic standpoint is to have his baby teeth taken care of. We sometimes tell our students that the best orthodontic appliance is a well-placed filling in a primary tooth. Look at this other drawing. Here the primary molar, this primary molar here, this primary molar is lost, and the permanent molar has tipped forward. It's encroached upon space which we had hoped would be available for this permanent tooth, a bicuspid, which will not arrive in the mouth until the age of 10 or 11. The result is that 3 teeth will now try to crowd into the space where there's only room for 2. In the front part of the mouth, the permanent teeth are larger than the baby teeth. In the side part of the mouth, the permanent teeth are actually smaller.
So that actually, the one thing that you'd want to suggest is that primary teeth be respected, that we don't say, oh, it's just a baby tooth.
That's right. Let's look at our first patient. I think we can show you exactly what we mean. This is Nancy. Nancy's a girl who is in the early mixed dentition stage. Nancy hasn't had any orthodontic treatment, and Nancy may not need orthodontic treatment. We don't know. She's rather at the crossroads, you might say. We're going to see in her mouth just the situation which I showed you in the drawings.
Well, actually, then all of the youngsters don't run into trouble, do they, when they have some primary and some permanent teeth?
No, surely not. They don't all run into trouble. The important thing is that the dentist must have a chance to diagnose the possibilities, the potentialities in each mouth. Now let's just turn around this a little bit, Nance. If you can see these teeth in the front part of the mouth, these 4 here that look a little jumbled are actually permanent incisors, the ones I pointed out in the drawing. On the side part of Nancy's mouth, we see the 3 baby teeth that we talked about, and clear way in the back there is the permanent first molar, the 6-year molar. If Nancy's primary teeth, those in between, are taken care of, and a maximum amount of space is held, why then her permanent teeth will have a good chance to find room in the jaws. We actually call this sort of work space management, the management of the space to the best advantage of the permanent dentition. It's really the only reason, well, not the only reason, but the most important reason for filling and caring for the primary teeth.
Well, Nancy, how old are you?
7.
And is this about the age when the youngsters might be coming in to be observed for this?
Yes, we'd like to see the children at 3 so that they can get their baby teeth filled. That's about the time they're psychologically ready for the dentist. And as the dentist fills the teeth, the modern dentist not only fills the individual teeth, but he looks for these, we call them occlusal problems. And some of them, even in the baby dentition, can be helped. Most of them, however, begin about the time that you see here in Nancy's mouth.
Was Nancy getting any treatment now, Dr.
No,
Moyers?
and Nancy may not need any treatment, but she is being observed, and should anything go wrong, it will be taken care of immediately. It's sort of a preventive type of thing. Let me show you our next patient, and we can then see a little girl. Thanks a lot, Nancy.
Thanks a lot, Nancy.
Bye. This next patient is Barbara.
Hello, Barbara.
Now, Barbara has a little bit different situation. Barbara's baby teeth have, some of them are lost, and the permanent teeth actually drifted forward, just as we talked about in the, over there at the drawing.
Barbara, how old are you, dear? You're 11. You're a little older than Nancy, aren't you?
Now, in Barbara's mouth, these baby teeth were lost, and after they were lost, the permanent teeth came forward a little bit, and it made rather a jumbled situation. Let's see just what happened. You will see in her mouth here now, on the side part of her mouth there, space. That space was once occupied by a primary tooth. Now the primary tooth's lost, and if we don't hold the space, the permanent tooth in the back will come forward. We hold it with a little piece of plastic. Do you want to show that to us, Barb?
So that actually Barbara's problem is that some of the baby teeth have been lost, at least one has been, And the other tooth hasn't grown up into fill the place.
Yes, in the lower jaw alone, she lost 4 of them prematurely. Now let's just look at this little appliance and see if we can't understand the problem a little bit better. Back here in the back is where the permanent molar fits. In the front, in this region here, is the location of the permanent incisors. This little block of plastic in between is maintaining the space where primary teeth should be, where we'd like to have them. It will hold an adequate space, and then as the permanent teeth come up, we'll simply cut away the plastic and the appliance will be lost. You want to put it back in mouth?
Barbara, do you mind wearing this, dear?
No.
Well, I should think not. You know, I had an idea that braces and appliances in your field, Dr. Moyers, always looked pretty fancy and perhaps covered every tooth in the mouth. This looks very simple and uncomplicated to me.
Yes, this the goal of interceptive orthodontics is to use these simple appliances as much as possible. I want to show in just a little bit the more complicated appliances about which you talk, but I'd like to show you Nancy's upper appliance too. It's a similar thing, but it has a little wire around the front to help align some of her anterior teeth, which were a little bit twisted and a little bit out of line. It's so much easier to do it now. Let me show you those complicated appliances you talked about, and then perhaps we can see some of the advantages of this interceptive work.
By interceptive, we mean that you're trying to stop the teeth from growing in the wrong position, or just what do you mean, interceptive?
Well, we mean this, that when a tooth or the bones of the face start growing in an abnormal fashion, it's so much easier to redirect it at the start of this misdirection, maldirection, than it is after it's widely divergent from where we'd like it. In other words, we can do in a few months in a 7 or 8-year-old what it sometimes takes us several years in the young adult dentition, say the age of 12 or 14. When we get a child that age, our only resort is to go to these rather complicated appliances.
The kind that I was referring to.
Yes, and the orthodontist would be lost without this appliance for the more complicated malocclusions. There's that bad word again. But his goal, actually, is to avoid the use of these complicated appliances as much as possible, for he can handle more children and give his service to a larger part of the community if he sees them early and can do this interceptive work. Certain cases, however, simply cannot be intercepted. This decision ought to be the orthodontist, and he'd ought to see them all young and decide which ones he can do in a simple fashion and which in a complicated fashion. Let me show you Barbara's mouth. This is the way Barbara looked at the start. I think you can see that her the space that was lost on the side and the malarrangement of her upper anterior teeth. Now, this is approximately the way she looks now. If you aren't used to looking at children at this age, it may not even look quite right. To me, it's beginning to look quite normal, and it seems to me to be quite an improvement over what we saw before. The appliance that Barb has is one similar to the one on the model. Now, if you look at the model, you will see a space right here where a large primary molar one time was. That primary molar was lost just as in Barb's mouth. And it's necessary then to wear this little plastic appliance which holds the space until the permanent tooth comes up. Sometimes we actually have to activate one of these appliances and push the permanent tooth posteriorly just a small amount. This is much simpler, of course, and easier on the child, and incidentally easier on the orthodontist than the complicated appliances which we discussed earlier.
So that actually the first two youngsters have demonstrated for us then the problem of space management.
Yes, the dental type of orthodontic problem. Now our next patient, Camille, is a little bit different situation. You remember at the start I said that some of these orthodontic problems originate in the dentition, and that some of them have to do with abnormal muscle habits, and some with disharmonious or bone growth. Camille is one of our so-called muscle problems. As the teeth erupt into the mouth, they come into a muscular environment. The environment of the strong, powerful tongue muscle on the inside of the mouth, and the muscles of the lips and the cheeks on the outside. Now, I want you to do something funny. Will you swallow for me, Miss Bucas?
Oh, I'd be glad to.
Where did your tongue go?
Oh, it went to the roof of my mouth. I hadn't thought of it before, frankly.
Most people don't, and it's probably a good thing if they don't. Let's just see where Camille's tongue goes. Can you turn your head over this way a little bit, Camille? Now, close your teeth, right down, that's it. Now, will you want to swallow for us? That's it. Now, let's try that again. Maybe Miss Bucas...
Well, I think I saw your tongue come forward.
There, see?
It certainly did. The tongue came right between the teeth.
Yes. This is what we mean by an abnormal muscle pattern. This tongue is functioning in an abnormal way. It's been forced to do this, usually by a sore throat condition. If you look at my hand, I think I can show you that. You want to turn your head around this way just a little bit? The tongue is shaped like an inverted letter L like that. My tips of my fingers out here are the tips of the tongue that we see when we look in a person's mouth. And the bottom part down here, where it bends down into the throat, we call it the root of the tongue, is situated between the two tonsils, one tonsil on either side. Now, if a child has a sore throat and the tonsils become enlarged and inflamed and swollen, right down here, you see, then they're in the way. For as the tongue comes back, it bulges out sidewise and it runs into these tonsils down here. Then a little bit of pain gets started, and reflexively the tongue is thrust forward. The child practices this habit, learns it, and does it rather of necessity for a while.
And then you have the problem of unlearning this habit.
Exactly. It's a muscle, and one can practice with it, just like a baseball pitcher practices throwing a ball. This is the way we actually treat the cases. For you see, the first type of cases, we move teeth. It was a dental type of problem. This case is a muscular type problem, and we must direct our attention towards the muscles which are functioning in an abnormal way. Let me show you how we usually do that. Camille, I want to show you something. Most people, when they swallow, open wide, and I'll show you now. Most people, when they swallow, put this part of the tongue against that part of the mouth. Can you put it up there? Good girl. Now, hold your tongue there. Close your teeth. Now swallow. Fine. Now let's try it once more. Open wide. Put this part of your tongue on that part of your mouth. Close your teeth. Swallow. You'll notice that when she swallows in this fashion, it's a little tough on her at first. She's not used to doing it. There's not so much contraction of her lips. And with her tongue back out of the way, and this pressure on the inside of the arch no longer present, then the normal contracting pattern of the lip movements during speech and so forth will actually move the teeth back and bring about a large amount of the correction, the lip muscles themselves.
Then actually the teeth will get realigned, you think, without appliances to sort of help pull those front teeth back?
Not always, but occasionally they do. In Camille's case, she sometimes carries her lower lip beneath her upper teeth, and that may be a little bit of a complicating factor. But we see a very marked improvement when we just get the tongue out of the way.
So that actually the major treatment is retraining your tongue, Camille. Is that it, dear?
That's right. And Camille and I will go over these exercises together. She'll practice them in the morning after she brushes her teeth, at noon, and again at night. All of a sudden, one day a time will come when she'll just be swallowing, and she notices she swallowed in a different fashion. That day we started to win the battle. However, sometimes when these muscles have been acting in a wrong fashion for so many years, it's a little tough. And they can't learn to do it so quickly. I'd like to show you on our casts another way of training tongue muscles.
Fine.
Thanks a lot, Camille.
Now, actually, I would think that it would be quite a job to retrain a child whose habits have been firmly established.
It is. It is quite a job, but not as difficult as you'd really think. You know, habits in children are not quite like what they are in older people. We're a little more set in our ways. These are Camille's teeth. You'll see the large opening in between the teeth here where her tongue comes. This we call an open bite. Most of these open bites are caused by thrusting tongues between the teeth. Sometimes, however, the same kind of a problem is caused by a thumb sucking habit. Now, this is one other appliance that is used, and this appliance is used for actually training a tongue muscle. You'll see the tongue lies in this part of the dental arch. The tongue would come up then and hit this appliance. There's little barbs on it. It feels it, and it gets back out of the way.
It might hit it just once or twice and be reminded that...
Not very many times.
That isn't where the tongue's going to go. I see.
That's exactly right. From the front part of the mouth, you don't see this appliance, and only the child and the tongue know it's there. We use a similar appliance for thumbs.
So that actually now we've seen a demonstration of what the tongue thrust, the tongue coming forward abnormally, what it can do to the alignment of the teeth. How about taking a look at our last youngster?
Our last patient is brought in for a rather important purpose. This is Ingrid. Now, Ingrid represents the third type of problem that we discussed at the beginning.
Ingrid, how old are you?
All of these orthodontic problems are not tooth problems, and not all of them are muscle problems. Ingrid represents the most difficult type for us. And I wouldn't want you to believe that the orthodonts can intercept or prevent all of these malocclusions. Actually, we can't. And some of the most difficult types, as represented by Ingrid, the best we can do is to minimize or ameliorate the problem. Let's look at Ingrid's profile. That's girl. Now, you'll see that the upper jaw here in the mid-facial region is a little bit forward to the lower jaw. This is because her upper jaw is grown in a disproportionate fashion. If we look in her mouth now, you can see how the upper teeth stick way over the lowers, you see?
It looks like, sort of like the upper jaw was winning the race and the lower jaw was far behind.
That's exactly what's happening. Our problem in treatment of this case is not to move teeth. The teeth actually are in the right positions on the bone. The problem is not to train the musculature because it's functioning fairly normally. The basic problem is to try to redirect the growth of the facial bones.
Ingrid, do you have any trouble closing your mouth, dear? It looks to me like your lips might not quite meet.
Yeah.
Do you have trouble? Try it for me.
You'll notice when she tries to close her lips, it's a bit of a strain because they have to go a greater distance than is normal. And it'll be impossible for her to keep her lips tightly closed all the time. However, when the treatment's over with this nice long upper lip, this will no longer be a problem. This is the appliance, one of the types of appliances that's used for treating this type of case. You'll notice that it consists of a little arch wire here with a couple little cat whisker things. I'm going to ask Ingrid to put it in her mouth. You want to put it in place, Ingrid? I'll hold the mirror out here for you. You see back on those first permanent molars, which we showed you over there on the drawing, there's a band around that tooth. These are the only two teeth in the jaw that are banded, one on either side. Then on the band is a small tube. Ingrid has just put the appliance in that tube on either side. She wears this appliance only at night. It's not necessary to wear it during the day. And then before she goes to bed each night, sometimes around the house in the evening when she's watching television, she puts this gadget on. Do you want to put it on? It's made of plastic.
And it's a beautiful pink. Very fancy headgear, I'd say.
That's what we call them, headgears. There's a little elastic on either side. Ingrid slides that forward, snaps it over these little extensions on the appliance out here. Now, do you want to open for us, Ingrid? That's the girl. And you see how it fits inside the mouth. Close your lips. Doesn't interfere with the breathing or with the normal lip action. This puts a force against the upper jaw and holds it back so that the lower jaw can go forward unimpeded. Now, if you look at the side of her face here, the face grows downward and forward, both of the upper and the lower jaw. Our effort in treatment of this type of case is to slow and impede the growth in the upper jaw and allow the lower jaw to grow at a normal rate. I think I can show you that on the cast 2 a little bit better.
Well, fine. Before you show me, though, I'm interested in having Ingrid tell me whether she can sleep well and whether she minds this fancy hat to sleep with at night. Do you mind it, honey?
No.
Did it take you very long to learn to wear it, Ingrid?
No.
Ingrid's an unusual patient, I might say. Most children take 2 or 3 nights learning to get used to it, and it's not unusual at all for it to be in the bedclothes in the morning or first week. But she's a pretty good patient. She probably had better luck than most of them.
So that actually this appliance is working at night while she sleeps, and she's not wearing any appliance during the day, did you say?
That's right. No appliance at all during the day.
Mm-hmm.
Thanks an awful lot, Ingrid. Bye. Now, I think we can understand that case a little bit better if we look at Ingrid's cast. Here are the casts, and I believe that you can see how the upper teeth are so far ahead of the lowers. Our job when we treat this case will be to hold this upper jaw back. Now, both of these will go downward and forward. If we left them alone, they'd go downward and forward. In 2 or 3 years, it'd have the same relationship. As it is, however, we'll hold the upper jaw back. Then the lower jaw can just grow forward just like that, and by and by we'll have a nice, normal relationship.
But will this treatment take quite a while, the child of Ingrid's age?
You know, we never really know how long it's going to take. It's dependent upon the growth of the bones, and we don't have any accurate idea of how fast they are going to grow. I thought perhaps you'd like to see a similar case that's been treated. I believe that you can see that these two are...
They look very much alike.
Yes, they're a similar type of malocclusion. This was a boy who started approximately at Ingrid's age, perhaps just a little bit older. And this case, this improvement that you see here, resulted in approximately 15 months of treatment. Ingrid, however, has been under treatment almost that long, and we haven't made quite that progress. It's a little bit slower. It'd be unfair for me to say that all such severe cases treat in 15 months. They don't. I think par would be near 20 to 24 months, although occasionally we get them to come out this nice and this soon.
I notice in several of these youngsters that the teeth look to me like they might be a little crowded and more apt to develop dental caries than normal mouths.
Yes, this is one of the problems of malocclusion. Malocclusion causes a higher incidence in the prevalence of dental decay. One of the reasons we straighten teeth and align them is to reduce the dental decay. Another thing is that teeth that are malaligned and irregular, as some of these you've seen, are far more apt to have a gum disease. We call them periodontal disorders in middle age. So actually alignment of the teeth in the young child is not simply a beauty parlor procedure. I wouldn't want to underrate the aesthetic and the cosmetic effects of the work, certainly not. But we're actually doing a preventive dental health service for types of problems that sometimes are not seen even until middle age.
Well, Dr. Moyers, would you like to summarize briefly for us the kinds of cases that we have seen in these 4 youngsters?
Yes. First of all, we saw a little girl who was beginning the mixed dentition age. Here we saw permanent and primary teeth, both in the mouth at the same time. This is a rather critical, crucial time. She's at the crossroads. If those primary teeth are well taken care of, everything will go just fine, and we'll have no problems at all. However, if we run into trouble and the primary tooth is lost, then the permanent teeth may drift, and this causes the first type of malocclusion we saw in Barbara, the type of problem which we call a dental type of problem that involves a malpositioning of teeth. These can be intercepted. Indeed, many of them can be prevented with proper dental care rendered by the family dentist. The second type of problem we saw was in Camille. This problem really wasn't singular to the dentition. It originated in a powerful tongue muscle. Similar problems can originate in lip-sucking habits or thumbs. And finally, we saw the most severe type of case, the one of Ingrid, which is a problem in the growth of the bony skeleton of the face. We characterize these problems by saying that they're dental, or they're muscular, or they're skeletal, according to the place where the problem began. We have our best luck in interception with the dental and the muscular cases, and actually all we do with the skeletal ones is sort of soften them up a bit and make treatment a little bit easier. Even a case like Ingrid, we may have to put a rather complicated appliance on at the end, but we've tried to minimize the use of that appliance.
Well, thank you so much for being with us, Dr. Moyers. And we certainly do want to thank the children and their parents for cooperating with us in presenting this program. Next, we're going to present the third in the dental series. It will be on dental caries.
Thank you, Miss Bucas. Tune in at the same time for Frontiers of Health. Frontiers of Health is designed to acquaint you with the modern knowledge and techniques used in your behalf by all of the health sciences. Ted Nielsen speaking. This program was produced on kinescope film at the University Television Studios in Ann Arbor. This is University of Michigan Television.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.